Hello and welcome. I'm Regina, your host and mindset coach. This is the Moms Who Achieve podcast, where we discuss motherhood, mindset, money, and everything in between to equip first-generation change makers with the tools they need to create the lives they want and deserve by managing their minds and taking massive action. I am super ecstatic that you're here, and I'm hopeful that with an open mind, you'll leave with exactly what you came for. Let's go. Hey everybody, I am back with another Healing Hour conversation with a friend of mine that I met online. Her name is Jahidah. Didn't we meet in the healthcare collective? So we're both in healthcare, and we signed up for a coaching program with Savannah, and I met her there, and I just remember hearing her talk about her business. We connected on Instagram, and everything fell in place after that. So thank you for being here.
Thank you for having me.
Yeah, I'm going to just let you introduce who you are. Definitely let us know how many children you have and what information you want us to know from there, and we'll get this conversation going.
Okay, thank you. So my name is Jahidah Roche. I am CEO and founder of the Healthy and Happy Woman Company. I'm also a physician assistant and a healthcare practitioner in terms of public health. I'm a mom. I'm a wife, I'm a daughter, I'm a mom of 3, 15, 5, and 2, almost 3, next 2 weeks. Girls, all girls.
Did you say all girls?
All girls.
Ooh. Yes. Okay. When you said that you were, I know you're a physician assistant, but then you said a healthcare practitioner. Can you tell us the difference between the two?
So there's not really a difference. I really meant public health practitioner, which is something that's different, because a physician assistant is a healthcare practitioner. The spectrum of healthcare practitioners are physicians, physician assistants, nurse practitioners. I put nurses in there because you do provide care. So when we think of a healthcare practitioner, that's the group of people, of names, of designations that we look at. A public health practitioner is somebody who's a little bit different, who's not clinical, but uses different philosophies and theories to help manage the public's health. So if we think about COVID, that's still a big thing. That's a public health issue because the entire public, it's a pandemic. Everybody suffers or can suffer. There's risks to it. There's epidemiology, which is a part of public health, where we track the disease. So if we think about how COVID progressed, that's like a big public health case study. How do we keep the public safe? How do we keep them healthy? And so I also have a degree in that.
Nice.
Yeah. Not epidemiology per se. I mean, public health is vast. It's also part of like the healthcare framework. So you have different subsets of that. But yeah, I have a background in public health.
And I like to point out, because a lot of my listeners may or may not be in healthcare. I know a lot of them are not actually. And when I'm talking to people about, should I be a nurse? Should I join healthcare? I love, in general, what I do love about healthcare itself is that you can be in healthcare and like practice directly with people, on people. And then if you're not a people person, but you still want to give in a way, like what you're speaking of, like the research on the back end. Like I know nurses and public health, clinicians maybe would be the term, that don't ever see patients, but still like play a major part in healthcare. So I love that.
Yeah, absolutely. I mean, when we think of what public health really fuels, its policy. So there's a lot of research that happens. So it helps the scientific community in terms of us practitioners who do bedside care. I mean, I don't do bedside care anymore, but it also helps frame policy, because your legislators look to see what the research says. Has any research been done in smoking in children, for example? What does that show? Is it a danger? Do we see outcomes that are bad for our children? And if the answer is yes, then those are the studies that get funded by the government to come do more work. And those are the studies that legislators either use or don't use to prove their case, to pass laws. So that's another arm of public health. So it's very, if you're into service, healthcare is service-based.
Yeah.
And it's a big industry. It's not just direct patient care, which is, of course, the bedrock of what healthcare is. But we have all of these other arms of healthcare that support the work that you do at the bedside, the work that I did at the bedside, in terms of the guidelines that we use. You know, if a patient presents with X, what are the guidelines that we use? You know, that's all fueled by research, studies, longitudinal ones, long-standing ones, to just see how patients do, you know, what the outcomes are. So if you're looking for patient outcome work or to be of service to impact patient care, you can do it from anywhere, from the bedside to the back end. You know, they all funnel back to the patient.
Yes, and I find that in acute care, which is where all of my healthcare experience, for the most part, I guess I have worked in like nursing homes and such when I was a CNA. I've worked in clinics, but for the most part, it's been inpatient, hospital, acute care. The floor and what the care that we provide, like it would be made or broke by the research, like our research team, our education team on the floor. So I've kind of got my own thoughts around that inpatient wise, but for you, do you find that there are Black or brown people like heading that, like doing the research on the back end, and does that affect the results we get and how we create policy?
So that's really interesting. It's not enough of us. So whatever you see on the inpatient side is mirrored in, let's say, the ambulatory side or just in the public health research space. There's just not enough of us. There's not enough of us that are being tenured into professions that, you know, the PhDs that are getting the tenureship. And then there's not enough of us who are able to reach us, because you have to have the support of your organization. And it is challenging. So whatever you see on the inpatient side, whatever, you know, you feel is, you know, bubbling up, it's also bubbling up on the, because I came from the inpatient side. I was critical care.
Okay.
Focus.
Yeah, so 100%. Definitely not enough Black and brown folks on the inpatient. I just was like, is that the same on the outside? So
it most definitely is. I mean, where you see a lot more representation is in the communities that are predominantly Black and brown. Unfortunately, they also are like the high Medicaid, the underinsured, the uninsured. And so they're under-resourced. So even if you are there to try to do good work, it is still a struggle because the resources are not being funneled there. So, you know, it propagates outside of the hospital walls.
Yeah. And were you, I know your background is not American. Were you born here though and raised here?
I am American. I was born here.
Let me rephrase that. That was incorrect. Like your culture, like your,
yes.
Is it African?
Yeah, you have an accent. I have an accent. Yeah. So I was born here, and I left at around 4, and I moved to Trinidad. That's where my mom is from, and my dad is from Jamaica. So I am a Caribbean woman. I identify as that. You can hear it. I can't hide it. That's where I was raised. Yeah. I spent about 18 years there. Went to school. My beginnings were there. And then I came back up and started college and started like my professional career. So yeah, I'm born in New York, Queens.
Yeah, so you are American. Your background as far as like how you were raised was the appropriate way to ask that. It was in another country.
Yes.
And do you find that what we're talking about underrepresentation and things like that is the same there? Because in my mind, I've never been and I've never lived there, but I know us Americans, when we think about it, we think of like mostly Black and brown people there, period. So like that's the vast majority. So does healthcare and the way we take care of Black and brown people different in those spaces?
Yes. So it's a very interesting dynamic. They're more Black and brown than not. I mean, we do have a very multicultural country.
Okay.
We have maybe about 50%. It's like almost 50-50, 50 of African descent, 50% of East Indian descent. I mean, it's not quite 50 because we do have people from the Asian community outside of India. I'm talking about, they could be Chinese, Filipino. We have that Asian group. And we have a South American influence now from Venezuela due to the political climate. And we do have people who have ancestry from Syria, Lebanon, but they're in the minority in terms of numbers. But in terms of healthcare, their system is very different. So Trinidad was a colony of England. And so our healthcare system is a replica of what England has, which is this very universal healthcare. And I don't know if you're familiar with the concept. It was
a little bit like Canada and different places.
Yes,
a little bit.
So very, very, similar. So in that respect, we're very different in terms of how we access healthcare. Now, the challenge that they may have that we don't have is, again, resources. It's how do we keep a system that people are not paying for, as up to date as we can to provide the services for the majority. So their challenges are not as similar to ours. But sometimes at the end of the day, if we're looking at outcomes, they may have some poor outcomes because of their system, not because of race, but because of just a system that, whereas ours in the US, it's very layered. We have the structural racism that we just navigate through without even knowing we're navigating through it. And then you have that, what we have to deal with from an interpersonal relationship with a provider or a nurse or whoever we come in to provide, to have care, our care contacts with, that racism or the bias that might be behind that's what we have to contend with a few more. They have to contend with some other things. So like resources, maybe under-resourced. There's a lot of resource issues that they may be having. I mean, I can't speak to it right now because I'm not there.
Sure.
Can I say it's falling apart? No. Do they do the best that they can to help people heal? Absolutely. But they have their own challenges, and it's not the same.
So it's like over there, they may have, their issues may be because of lack of the resources. In some instances, we're here, we have the resources, but because the way you look and my bias towards you, you may not get those.
You can't access it. And maybe it's also for them, and this is maybe a little bit of a stretch, but when you think of being a colony, you weren't designed to be independent from the host country. And so once they gained their independence, things shifted in terms of how they were going to get supported. And so it's through this phase of transformation, I think, their Independence Day, today's the 30th, is tomorrow, they are still becoming. And so just like the United States was a colony of England, and 100 years, 200 plus years later, we're still becoming. And the framework of racism was already set. So there's still some relics of that in their infrastructure that they're going to have to work to, upend. But they do the best. They do the best.
Yeah. And so this is just my own curiosity. Is it, I've never lived somewhere where white people weren't the majority or didn't feel that way. So over there, do white people experience racism because they're the minority? You know what I mean? Or like, is it weird to see a white person? Like, this is ignorant. I already know. But I need to know.
It's not weird. I don't know if they would consider feeling like there's a bias against them.
Okay.
My experience is that they're like almost a league of their own kind of thing. They're sometimes the people who have business. So this is where it becomes similar to here. They're the ones who have some of the economic power and maybe some of the political power in that they fund, so,
Got it.
I don't know if they can say that they experience racism. Um, I feel like we all kind of blend.
Anyway, yeah.
Yeah,
And of
so
course, like when you talk about like the definition of racism and what that really means and that white people can't experience that. So that probably was the wrong word to use, but like being in a space, I couldn't imagine being in a space where they weren't the majority, where it was
right.
like normal to see black and brown all the time, everywhere. So just speaking it, I just thought to ask you that, like speaking of
Yeah,
something
I
who's
mean,
been over there.
and that's pretty much the life that I knew. I mean, didn't feel and I'm a unique individual because I toggled between that world and this world.
Yeah.
And so I
It was
all of
just
it
what you
felt normal.
was.
Yeah, it just was normal. I mean,
Yeah.
and
Yeah.
and coming here also didn't feel abnormal because I just knew that this was the landscape. So
Yeah.
I just had a unique experience, but it didn't feel uncomfortable. It doesn't feel weird. It just is. Like if you ask somebody whose life is there, they're like, oh, this is what we know. Like we
Right.
don't know the other. So
Yeah.
like you don't know what it feels like to be around and surrounded by all the shades of brown. All the like they don't know the opposite.
It's just
Um
their thing. Yeah.
yeah.
Yeah. I
Mhm.
love that. So then what tell us about like how you decided and how you went forward with creating the Healthy and Happy Woman Company.
So it was a pandemic. I was also pregnant.
Okay.
um
Yeah.
and we had been remote, and I mean even before the pandemic, the idea of disparities um was always there in the forefront. Like I've experienced some health challenges over the years, and some of the way I'm a clinician, but some of the ways that I was handled
Mm,
um by some of the providers I saw, I had to question why if I presented with a chronic headache was I given Percocet and
mm,
not really listened to. um why wasn't I examined fully? And it's interesting because I don't when I navigate the healthcare system as a patient, I'm not forward with I'm a physician assistant. I'm just
right.
navigating as a patient. And
Same.
based on what's happening, then I might just have to let you know that I know something too. And it was just a really interesting experience. Another experience I had with another provider, not a white male. And when you are unwell, even as a clinician, you're at the mercy of somebody else.
Yes.
And it's a scary place to be in when they don't see you.
Mm,
So they don't see you as a human. They may, and listen, it's not even that it's unintentional, it's that implicit bias, right? So you're gonna give me a medication to help a symptom that could probably affect the entire future of my life.
yeah.
And he's like, yeah, it'll work. Just take it. It's temporary. It'll push you into, menopause temporarily. I'm 20 something. Huh? And I take it. Like I go, I fill a prescription and I take the first dose. And I was like, I vomit. I don't feel good. I said, it didn't fit right with me. I'm a clinician. But in that moment, I am unwell and nobody has had a full conversation with me. And so when I kind of recount my experiences of like the missed opportunities, even as a clinician taking care of patients in critical care, we had a patient who came to the floor and stepped down, a Black woman. I forget what surgery she had, but Regina, she didn't look right.
Mm,
And I'm looking at the Foley, and the urine is that dark, dark. I said, let me go and do a proper physical on her. No, she is a brown skin woman like myself, so you can't see jaundice.
right.
You can't, I don't look yellow, but her eyes were all yellow.
Mm,
So let me just run the labs to confirm my suspicions. And sure enough, she had some biliary issue going on. Now, my role was to manage her acute post-op, stay.
Right.
But that would have been missed because she was getting ready to be transferred to a regular bed.
Yeah.
So it's in those spaces when I recount and had time to reflect what's happening with us. And the gap is clear. When I started thinking about pregnancy and my pregnancy challenges, if I didn't have a Black female provider, I'm not sure if I would have the children that I have, or if I would have been alive. And we all see and hear of the Black maternal statistics, how poor they are. Young women are just dying, post childbirth, in childbirth. You have to have an astute provider who sees you. And so obviously there's a thing that's missing, one, in the medical education space, and two, when we interface, when we present with the patient, are we just presenting to solve symptoms, or are we trying to help the patient? And that's where I started really thinking about, but where's the gap? In the ambulatory world, the gap is a communication gap. Providers, unfortunately, want to do the best that they can for us, but they have 15 minutes.
Right.
So you can't really, how much can you do? And so that's really where I started thinking about and ideating about what can I offer, especially women, Black women, women of color, who have all of the statistics, not even, we don't have a positive statistic. It's like, we're overweight, we're the most likely to this, we're the most likely to that. And I'm like, okay, there is a space for more education. And in public health, there are healthcare educators. So, but I think it has to go a step beyond. So there's the education about lifestyle and behavioral changes, but then there's the education about what this disease is doing to you. And then there's, how can we help you? Yeah. Now, it's not going against what your doctor has prescribed or suggested. It's like, where can we now, you're on the medication, but what changes do you need to adopt? What is unique about your situation that we haven't considered? And that's where I, wanted to build in that space, in the bridging of,
Yeah, because one of the things I hear you saying that you do, and we can get into that, exactly what you do, is the personalized care that just doesn't come from healthcare, for many different reasons, color being one for sure. Like you talk about that, and also the time, the resources, and where they allocate money to. And let's just take it all the way back to the education that even myself, nurses, physicians, nurses, whomever, all healthcare workers are getting, and what that education really is like. Because when I speak to nurses, or I've never been to medical school, but for sure nurses, we're taught very textbook, very things that are not even really still in practice. Because what would that mean? That would mean constantly updating the books, constantly updating the curriculum, and just how primary school, like, these kids are learning from curriculum that was created 60 plus 70, 80 years ago. I find that kind of shows up too in healthcare, in our schools. And so we're coming to the floor, coming to the healthcare space to take care of folks with book education that may or may not be updated necessarily. I got maybe a class or two on cultures and what does that mean. And I see it every day in nursing, where particularly non-Black and brown women, men, or whatever, don't know how to properly communicate, honor, and it's not even just Black people, there's all different kind of cultures around. So we're missing that piece. And it's just so much that's missing from the healthcare that I feel when I talk to my Black friends, my brown friends, causes us to be like, I'm gonna wait till very, very last minute before I go get seen, because it just doesn't seem as though it's a safe space.
Yeah.
And when you talk about your experience as in the hands of healthcare, it is very interesting. I've had 4 children, so I know what that's like, and I've had like uncertain things happen in all of those births that I can tie down to not being listened to, being rushed, things not taken into consideration, like all of those things. And I can definitely feel you when you say, yeah, I'm a clinician, but you're unwell, and it just changes the trajectory. Like even when my kids, like something has happened to my kids over time, like I don't know what to do. Like when you're in the overwhelm of you or your family, I don't care how much you know, it's like now you like your well-being is really in the hands of someone else, because one, you probably can't even really think straight. And then, I want you to speak to, before we get into like what exactly you do, what did you experience when they knew you were in healthcare in some kind of capacity, like the before and the after?
So I'll give you the emergency room story. So it was a resident actually. Maybe he was third year. So I went in because I was just having headaches. And the reason I went to the emergency room, which I'm not necessarily keen on doing, is because there was an outbreak of meningitis in my community. And so I was like, it's far-fetched, but let me still go. And so once he started like rushing through the encounter and saying, okay, I'll just give you some Percocet, I said, excuse me, I still have to work. I work a night shift. How am I supposed to work with Percocet? And he goes, are you a nurse? So that's number one. I think a lot of times in my experience, nurse gets floated around because I'm Black.
Yep.
And female. I can't be anything else. I have to be a nurse. I said, no, I'm not. I said, but what is your plan for me? And so he's like, well, let me get the attending. I said, well, do that. Because you have to get the attending anyway. You have to present to the attending. You don't sign off on me. You don't discharge me. And the attending did more. He actually touched me. He examined my eyes, but it didn't change the plan. And so it was interesting, but I'm also still not well. So I can't go. I'm not in this space to go back and forth. I was already annoyed with the encounter. I just needed to leave because I knew that you couldn't resolve my issue.
Yeah.
So that was pretty much it.
Yeah.
Yeah.
I've seen it in my experience, and like I'm like you, I don't talk about me being in the healthcare space at all. But when it comes up, and it has, especially in particular with my kids, or even when I'm in the hospital having my children, it's come up, and I see it too as a nurse. I see when you're getting report, oh, their mom is, a doctor. It's like this untalked about thing where if someone's in the medical field, we need to be better. We need to do better. We need to be on our P's and Q's, which shouldn't be that way, but that is the reality. Even, things that were allowed that were, oh, I was told you were an ICU nurse. Like when I had my last child and a lot of complications happened, and I saw how people showed up. Whereas if they didn't know that, I'm not sure they would have. I'm not sure they would have like taken the extra step or like explained something or made it make sense before they brought it to me, because they were maybe thinking, well, maybe she won't, I need to make sure I know all these things. So I think a lot of it is normal human nature of like feeling like, want to make sure I do right because they might know more than me, or they might know that I'm not doing this appropriately.
Exactly.
But the other part of it is this energy that I've always felt like people, even not pertaining to healthcare, if a family comes in or a patient comes in and you see their family and how they may be treated, dependent upon how ignorant the family could be, or do they look like they have money? Do they not? Like I see all of that happening, and that is definitely about color, but also not. It's also like in general economic status and how do they carry themselves, so that's why I wanted to know.
Looking from reverse as now a physician assistant, I've had situations where we've had a patient on the floor who had a cabbage, came up to step down, and he is an immigrant. He he was immigrant, he was overweight. And I'm going to give you the strangeness about this story. It wasn't just whites. It was us also, people of color, people from different cultures saying, oh, he's lazy.
Yeah.
Regina, he wasn't lazy. He had a cardiac tamponade. So he had a huge pericardial effusion and it just went downhill that night. My point is we all do it.
Yeah.
So yes, predominantly it happens to us by, our white counterparts, but we also,
yes,
because of that training, the training isn't going to be, we got the same training that they got. So there's some other narrative running in our mind about a person when we look at that, whether they're Black, immigrant, we walk into the room with a bias, and you have to have the intention and be deliberate to be like, listen, let me listen. Let me take a moment. And I'm not suggesting that I haven't done it, but I'm saying we all have to recognize that we also can do it. We Black and brown can do it to Black and brown.
Yes.
It may not be because they're Black and brown, but as you said, it might be because they have a different socioeconomic status, or you perceive them to have one that is lower than yours, or they may be on drugs. Because I remember as a student, we had a patient who Mr. Mac, who was a drug user, and he ended up with a huge abscess. That it was a whole thing. And you're tempted not to give him because you start the care that he needs, because you start thinking of him as less than because he's a drug user, not really understanding that he probably at some point was just like us, walking around normal, and then a situation happened, and now this is where he is.
Yeah, or withholding.
Yeah.
Withholding medications because he's a drug user.
Or the care that you need. So you may not withhold, but you may not be tender. You may not be gentle. And I'm not suggesting that they're the easiest patients to deal with.
Yeah.
But, it's trying to find the space in between to give them the humanity that they deserve, So, yeah.
Yes. And that's a whole other conversation that I'm going to take note of that because caring for people I've cared for folks who are pedophiles and who are, convicted, for a lot of different things. And so that bias, like that's just a whole conversation of how do you show up as a human being with feelings, detaching your beliefs around what they should and shouldn't get. And it's a whole thing. So it's so much to consider in healthcare. And that's why I really find it important to have you on and have this conversation, because what you're providing when you talk about filling that communication gap, that gap you see, and the business that you've created to help, especially Black and brown women, talk about like, what does that mean? If someone is in healthcare now, or they're having some issues, they're not really, their needs are not being met, they're confused, they don't know what to do. Where do you come in for these patients?
Okay, so I have a client who was told by her provider, you're pre-diabetic. She's like, okay. So you need to lose weight. You need to exercise more. Okay. Come back and see me in 3 months. Now, what does that mean to her? She doesn't know how. Like, it doesn't see, it's not as intuitive as you think it, as people might think it is. And so that's where I come in. Firstly, you don't even know what prediabetes means. You know it's before diabetes, but what does that mean?
Yeah.
So it's trying to fill that educational gap. What does it mean? It's something that you can't feel yet, but doesn't mean things are not happening. So I kind of try to get to the science of it, not overcomplicating it, making it really easy for them to digest. So we move out that space. So what does it mean for that individual in her season of life? Because we're not in the same seasons.
Yeah.
To eat differently, to exercise, to sleep better. Like, we have to look at all of the things that contribute to the thing that he told you to do, which is lose weight. So if weight gain is a factor, or being overweight or obese, then we have to peel back the layers. And you got to understand what that means also, because we don't really understand that. So that's where I come in. I come in to kind of fill all of those spaces and give you the information for you to now settle with it. Yeah. And then can start making change, because the change part, so we all can lose weight. Like we know how to do that. We don't eat, calorie deficient, you will lose weight. But can you sustain it? And what is a healthy weight range for you? It's like having those conversations. Mm. If you lose weight, yes, things will improve in your lives. Can you keep it off? And that's where another set of education comes in, because it's not just what you eat. It's your life. It's your lifestyle. And we talk about lifestyle modifications in public health, and we talk about it in healthcare, but I'm bringing it very, very granular and specific to that person. Because if you tell me, well, I work the night shift, what that looks like for the person who's able to sleep at night is very different for that person. So we have to figure out what will work for you. And that's pretty much my process. It's a lot of educating. It's a lot of understanding what your patterns are, and then finding the opportunities to interrupt habits that no longer serve you and the goal that you're trying to achieve. And so for that client, it took about 18 months for her to get her hemoglobin A1C, which is that marker that is used to determine where you are in the spectrum of diabetes, normal or pre-diabetic, to be normal, and lose 20 pounds. Because there's a lot of trial and error. There is no one way, one size fits all. It's what works for, and we had to do a lot of science. I got her, I said, well, try to see if you can get a glucometer. So she talked to the doctor, and he's like, nah, you're not diabetic. You don't need that. And the insurance company won't cover it.
Yeah. Wow.
So here you have about 9 million people in the United States with prediabetes. 9 million. And you're telling them to lose weight. Okay, check. That makes sense. Exercise more. That makes sense. But they don't know what their blood sugar is. They don't understand what that looks like day to day. They don't know what their fasting looks like. But once they cross the threshold and they're diabetic, here's a glucometer, monitor your glucose. It doesn't make sense.
Yeah.
So we just got one from Amazon, and we started looking at her fasting. We looked at her postprandial glucoses. She had time. So, because of the season of life she was in. So we could do the science. It may look different for somebody else who's a working mom who can't do all the things. And what we were able to find were, okay, her fasting was high. And we also needed to understand what she was doing the night before. How late was she up? How late did she eat? And we started just, it's the smallest modifications over time, but we build on it. We try to settle in. It must feel right to them. It's not about depriving or, okay, we just can't have this thing anymore. No, when we strip away everything that we've had, especially if we're tied to it culturally, we're less likely to stick to whatever that new regimen is. So it's not to strip away your cultural ties. It's to make it make sense.
Yes.
For what your goals are. So yeah.
And that is so beautiful, because in this 15-minute every 3 months, 6 months visit with this doctor, it is not happening. And I'm hearing you talk about providing the education, yes, helping them to understand, well, how many times does someone come home with a paper like, well, this is what they said, and I don't know any, and then you get on Google and you don't know,
yes.
You get 10, 15 different answers, but them coming to you, oh, this is what this means, and going down to the education, the science and all that. But I'm also helping them to ingrain a new thought process. Because like you said, if you need to lose 20 pounds and you're changing your diet, your sleeping, eating habits and all that, in order for that to sustain in the longevity of it all, you have to have different beliefs. You have to have different thoughts. You have to have a different way of doing things. Whereas that's why people, you follow this diet, you'll lose 20 pounds. Yeah, you will. But when you get to that goal, then what? There was they talked about when Oprah talked about that time she was on that liquid diet and she lost those 60 pounds, looked amazing. And she said that when she left, she came on the show and everyone was applauding her and it was such a good thing. But when she left, she was just so lost and scared because I lost the weight. Now what? I mean, the mindset hasn't changed. The reason I'm doing this, I've already gotten the goal. Now what? So she went back to like how she was before because she didn't really understand her body and like you said, everyone's diet is different. What I can eat, you may not be able to eat and keep the weight off. So I see you
Right.
really giving that personalized, this is me and you on what works for you to achieve your goals and then sustain those. So them, like, of course it took 18 months. Like she became a whole new woman.
Yep.
I
Yeah.
love that. So
Essentially,
go ahead.
no, what I was just going to add was we also are in a culture of we need things done now, right?
Yes.
So we want to lose the weight now. We want to look like whatever we see on Instagram, Facebook, wherever we see it now. You know, we're talking to moms. We're moms.
Yeah.
You've had, you know, you want to snap back, you know.
Yes.
I'm not opposed to the vanity. Don't get me wrong. I like, we all like to look good. But we must put health first. We must do it in a responsible way and understand that what you may have been prior to having your children may not be what you look like going forward because of all of like we don't even give having children the credit, the space,
No.
you know, the changes that happen in our bodies.
Yes.
Because of us carrying another child, another human, is tremendous. And it doesn't mean that we have to not be unhealthy, but it may not look like what you were prior to. And we have to start being okay in those spaces and shifting from I need to lose the weight in 3 months because I have a wedding versus let me just pace myself. Because I do want to keep it off, not just lose it. And so that's where I think, you know, we have to get to, you know, just in general as a society. And not to villainize anybody who is overweight. Also, like, you know, the stigmas that go along with it. You know, from the minute you start talking about weight as a clinician, people start seizing up on you. I know, I didn't eat right. I had a, you start hearing it. I'm like, but that's not what we're talking about. Because a lot of it is not even our fault. We've been sold on certain foods being healthy. We've been indoctrinated into fast food because our lives are hectic, you know. So it's sometimes not even because you are eating or overeating. It's just a way of life. So we have to figure out how to, in the life that we have, where we have opportunity to do a little bit better. And that will move your dial and the needle a little closer to the goal. It just will take a longer time.
Yeah. And the things they're not talking about in these doctor's appointments when they're saying you need to lose weight, need to eat different, is even the science behind how our diet system and the way we eat fast food and all that has just, it's addiction, and it's addiction by force, right? Like the foods that we eat, they become addictive because of the science they do, because of even the ads and things. They pay these scientists, sociologists so much money to get us to, oh, well, I think this is healthy, and this education is not happening in the hospitals. I see patients diabetic on 200, 300 carbs on their plate, you know, and they're on a diabetic diet. It's like, it's nuts. So they're not getting the education on the inside when they're in the acute care, when something's happening. When you talk about like the Band-Aid, like that is what's happening. Oh, let me give you this, get your sugar down. You know, we put them on an insulin drip. They come in, sugars in the 700-800s. We put them on a blood sugar drip, few days, they go to the floor, they go home. There's been no education of like, how did you get there? And how do we work with you to get you down? Even when you talk about diabetes educators and things like that, their appointments are only 15 minutes, you know?
Yeah.
It's crazy. So what you're providing very much is something that's missing in healthcare, 100%.
Yes.
So how does it look to work with you? If one's interested, how do they reach out to you? Like, how do they do that? And what does it look like?
So there is an intake form. You can reach me on my website, hhwomanco.com, and we'll start talking, for first half hour consultation, just so I can get an idea as to what your goals are. What is it that you're trying to achieve? Are we going to be aligned? Because it is a commitment. It's a commitment that they have to make to themselves to see this through. And I'm really transparent with the journey. It's not really we're not just going to be focused on exercise and food. We're going to start touching other areas of their lives, and they have to be willing to be honest, not to me, but to themselves. And so, we use that first half an hour to kind of tease through if this is, a relationship that we would want to embark upon. And then once they agree, then I send them a whole slew of things that I need to understand. I need to understand who you are from a health perspective, what your current symptoms are, and like your family dynamic in terms of your family health. Because I think a part of what we also overlook is the power of women in the family and how we shape the health of the family.
Yes. Wow.
Wow. So if we can get mom healthy, if there's a dad, a husband, a partner, and they will also follow suit without you having to even make a suggestion. Because once you're consistent in what you do, they will follow suit. The kids will follow behind. It's not going to happen like this. Again, we look for it like, oh my God, it's working. It takes time. And so, a big part of my philosophy is if you can get healthy as the mother and the wife, or the woman of the house, then whoever lives with you will also get healthy. And then by extension, the community can get healthy because there's that trickle down effect. So yeah, it's a lot of that. And then we start meeting twice a month. Right now I do like one session, science, like we have science embedded in it. So like I did a session the other day and, I kind of tried to unpack the definitions of obesity. And she was like, oh, I didn't know that obesity was considered a disease. I didn't know it was considered relapsing. So it's just sprinkling that stuff inside of a session that grounds what it is that we do and how we do it. And then we do, lots of journaling is required because I need to see, I can't help you unless I see what you're doing. And, and then we tackle what we see. We address what we can see. And specific about a 6-month program. And we work through your challenges. Yeah. And my hope is to leave you with tools that you feel comfortable employing. So we have tools for when you're home, and then there's some tools that we can use when we're out, when we dine out. There's sometimes we can't use any tools. Like I went to, Sesame Place this weekend, but I couldn't use any tools. It was just, it was what it was. And we have to be okay with that too.
Like, because that one time is, and that one time is not what caused someone to be overweight or have diabetes.
Exactly. But I can't tell you, when you start your journey of transformation, when you have those weekends, you're like, oh my God, what is this? Nothing tastes right to you. And that to me is when you know that it's starting to work, because that mind connection to your body has now settled in, and you're like, I only want one fry. That don't look right.
Yes, I love that. And the quality of foods you will eat and those kinds of things.
You become more discerning, and I also take into fact, so some people might be like, oh, all organic, it's expensive. We have to be honest with where that person is financially also. What can they actually do? Because what you're not trying to do is stress them out, try to heal this thing by stressing them somewhere else. So we figure out ways, like frozen food section is a good place for veggies. Like it's cheaper, buying vegetables seasonally. It works when you can. If you can find organic things on sale, that's when you pick it up. If not, it's okay. Like we can work around what your finances allow. Doesn't
Yeah.
mean you can't be healthy. You can't achieve health, better health.
Yeah, I think a lot of us, just a perspective of like women, especially moms, like we have this all or nothing mindset. Like if I can't do it all, then I'm not doing anything. And we don't know that's what's happening in our mind, but that
Yeah.
is what's happening when you get overwhelmed and you quit because something has gone wrong or you can't follow things to the T. So I love how you help them on a personalized space.
Yeah.
One thing I wanted to, when you talked about the power of the woman at home, like that is such a close thing for me as I've discovered that myself in my home. And when you talk about like the key, the partner will follow, the kids will follow, share with us your journey. It's a two-part question, like you with your children and how you're building your business with having children, one of which is very small. And what that looks like and then how you see that has affected them for the better in what they choose to eat, how they choose to show up, what they see you doing and they see as possible.
I mean, it's been challenging starting a business. Starting a business because when I really started, I had given birth. So I had an infant and then I had a toddler. And I would say that it was a little bit easier then because now I feel like the 5-year-old is still in that toddler phase ish. And the toddler is really a toddler. So now it's like I'm constantly involved with them and less on the business side when I'm home or when they're with me. But I have to say that they see mommy eating a particular way. And my husband also is also health conscious. So they know daddy exercises, they know mommy gets up early and she tries to get her 10 minutes in because that's all I can squeeze in.
Right.
They see the food that I prepare. Are they eager to eat it? Sometimes no, but they're seeing it. So this is how it starts. The messaging is there. We don't shy away from having conversations about the importance of whole food versus the sugary snacks. I mean, I try to limit that as much as possible inside my home for them. But I mean, they go out, they go parties, so I have to give in that respect. But they know, like the 5-year-old was in camp and they went to a trip and somebody asked if she wanted a slushie and she was like, no, my mom said no, that's not healthy.
Yeah.
So it's like she's like, Mama, I know you said we can't have, that's too much sugar. That's how it starts.
Yeah.
I'm not trying, and some parents might think, well, oh my God, they're not having fun. But they are. We just find other things. That doesn't define fun. Again, it's been sold to us that we have to have these things as part of fun or a reward system. But there are other ways, and it pushes us to be more creative. If we think about our ancestors who didn't have slushies, there's fun other ways. They enjoyed food differently. Food is a way of communicating. It's a way of connecting. It's also our source of living. Slushy is not a food.
Yeah.
So like there's a lot of pushback that I would receive when it comes to how and what I expose my kids to in terms of drink and eat, in terms of highly processed things. But whole food, you can't lose with that. Just cook.
Yeah.
And if cooking is not your thing, we have ways around it. Like we're not stuck just, oh, I don't want to be in the kitchen slaving. You don't have to. There's ways around it, and you still can give your kids something nutritious, and it doesn't have to be not fun.
Yes. And I find that this is really breaking the generational cycles of what we see and
Absolutely.
us. I know me, I've experienced of not knowing how to have fun without the bad foods because it was so attached to the fun. And so by what you're doing and all of us trying to do this and be more health conscious on what they're eating, we're helping to break that thought that, oh, well, I'm not having a good time if I don't have ice cream, if I don't have, so I really love that. And one example, I know you have your 5-year-old, but for those listening, my son is almost 18 and he was going over a friend's house quite often. I'm like, you're always going over there. What do you want? He was like, oh, mommy, they have so much stuff. They have all the Oreos. She buys like 10 things of Oreos and this and this. And he's like, we can eat them all. And I'm like, oh. And so I'm like, do you think that do you not like that I don't buy that stuff? Or, what do you think about that? And he was like, well, Yes, but however, you still buy it sometimes, and you're actually these were his words, a teenager. You're actually showing me how to eat in moderation, that I don't need all of that. Yes, I would like the house to have all this junk, but the fact that you don't do that is teach me that we don't need it and all that. And also you do bring it in sometimes. So it's not like we never get it. So for those, it pays off. Like what you're talking pays off. And like you said, I don't control what he's eating when he go over other people's houses, but I just try to model the behavior in mine. And that is where, when you talk about the woman, like really changing the trajectory and like leading by example, that's what shows up for me.
Yeah. Yeah. And I think it's awesome. You have given him tools to take into his adulthood about what moderation looks like, what excess and overindulgence is. And, we're talking about food, but it can be anything.
Yeah.
And so food is that example that can transcend across, your sexual behavior, all of these different things. It doesn't just stop there, because I feel like what we're doing using food is setting up the boundaries and giving you permission and telling you it's okay to just eat when, like, understand what's happening with you, understand your cues. Are you hungry? Like, check in with yourself. You had enough, right? You had enough. Like, you had enough. So let's just stop. Like things like that. So kudos to your son.
Yeah, well, thank you. Thank you for what you're doing in community. I 100% agree. When you change the woman, you change the family, you change dynamics, we change future generations. So I will definitely link all of your website, your social medias, you guys. I'll put that all in the show notes so you can check her out. Please follow her. Thank you for what you're doing in community, and thank you for being here today.
Thank you for having me. It was a pleasure.
Thank you. I'll talk to you soon. That wraps up this week. I hope you found value. Please share with a mom friend, subscribe, and leave a review. This helps this podcast to get into the minds of those who need it most. I would love to hear what you think about the episode. Find me on Instagram and Facebook at Moms Who Achieve. Looking forward to chatting with you next week. Take care.